Good morning, everyone. Welcome to New York, here at Mount Sinai, for our monthly peripheral endovascular live case webcast. I am Karthik Guja, and I have with me Dr. Sardar Farhan. We are here to go over the live case with Dr. Krishnan's team, which we do monthly. The previous live case webcast has been archived in www.ccclivecases.org. Our next monthly live case webcast will be on July 29th, the last Wednesday of the month as usual. And please do email us if you have any questions on our website, and we'll be more than happy to answer your questions. Without any further delay, we'll go to the cath lab where Dr. Krishnan and Dr. Kapoor with their team are waiting for us with an exciting case. Good morning, Dr. Krishnan. Good morning, Dr. Kapoor.
Good morning, guys. So we have a really great case. We've got our team here as always. We've got Dr. Kapoor next to me. We've got Dr. Reza, who's our interventional fellow. You've got Dr. Cameron, who you all know is our endovascular fellow for the year. And of course, Ray Lascano and Elizabeth, our dedicated endovascular structural NP nurse, and Damien, who's always been here with us as well. So we've got a really fantastic case, and I think it's going to involve a lot of decision making and a lot of different ways to treat. And so without further ado, we're going to go ahead and get started with the case presentation with Haroon. Go ahead, Haroon.
Can you pull up the slides for me, please? Hi, good morning, everyone. Next slide, please.
I'm just going to move while you locate it.
Yeah, it's right there.
Can you go to the next slide, please? So our patient is a 60-year-old gentleman with a past medical history of hypertension, diabetes, dyslipidemia, and smoking. He presents with left greater than right lifestyle-limiting claudication, Rutherford 4, that has progressed to pain at rest. His medications include insulin, aspirin, amlodipine, metoprolol, lisinopril, atorvastatin, cilostazol. As part of the non-invasive workup, he had an ABI with exercise done. He did the exercise for about a minute and a half and terminated with muscle pain. His ABIs with exercise were on the right 0.95, 0.96, and on the left 0.92. That dropped to 0.78. As part of the non-invasive workup, he had the ultrasound done that showed occlusion of the left popliteal artery. He had a subsequent angiogram done and is now referred for further intervention. Next slide, please. So here are the representative images of the prior angiogram. As you can see on the left is the
get in right there.
Go back.
I think so.
Is the lower extremity runoff on the left side and DSA of the foot on the right.
See, there's a little
that's enough tube right between the two.
We have both ready.
Okay.
As you can see, there's very minimal, if any, disease in the SFA.
Oops.
Popliteal artery is a CTO that reconstitutes after the TP trunk into 80 PT and peroneal arteries. Can you play the DSA for me, please? Thank you. And there's about a vessel and a half runoff down to the foot. Next slide, please.
Right there.
Okay, so these are the DSA images of the popliteal artery in the LAO on the left and RAO view on the right side. As you can see, there's robust collateral supplying the AT, PT, and peroneal arteries.
I don't know if that's it.
There. I think it's just coming parallel behind it.
Give me a wire.
Can I give me a command wire?
Save the floor. Save that.
So our strategy in this case
Hold
for
on.
the planned procedure is get a contralateral CFA
Give me a
access
command
on the
wire.
right side for the left popliteal CTO versus an ipsilateral pedal axis.
Woolly's fine.
If you have any problems crossing antegrade,
Command is fine too.
use a glide wire with a catheter support for crossing. True lumen versus subintermetal tracking re-entry if you're unable to cross with the above support. Switching to an 014 wire for intervention, atherectomy, balloon angioplasty, and bailout stenting in case there's a dissection or a recoil.
Okay, fantastic. So Karthik and Sardar. So we have I'm going to have Vishal go over the film. Go ahead, Vishal.
All right. So, like as Kamran presented, pretty much the same picture, but we'll give you better views of it. So we take the right side runoff, looks good. This is the left side femoral DSA. Nothing impressive in the SFA segment, and you can see there is quite good runoff, indicating that the patient has had collaterals and worsening symptoms. Yes. And if you go on to the next one, now you're going to start see the popliteal segment where your CTO is. He was moving a little bit because of the dye, but right there, this is our popliteal coming down, and here you can see It's almost occluded, reconstituting pretty much at the bifurcation / trifurcation where the PT and the AT comes out. AT is not well visualized. And going down, you can see the patient has, like you said, almost a vessel and a half runoff. Good PT, but AT has some disease proximally. That's why it's underfilled as well. So it's filling in late, but the PT is going down all, and it's probably the dominant vessel right now here.
Yes.
Go
ahead. So when you see something like this, I think it's very important to understand that you need when you're planning a procedure like this at home, when you look at what Vishal showed you at the level of the popliteal, this is probably one of the most complex occlusions that you can get when you have a blunt occlusion with multiple collaterals coming off, and then giving you the posterior tibial and the anterior tibial. But what you need to do is at this stage, what we always say here is you want to take a catheter down, and as you take a catheter down, you want to inject locally to see whether you see any sort of stump. Well, we've prepared here, ready to go. Pedal access. Vishal is ready with the ultrasound. We're also ready to try from up and over. But I always believe the first attempt should be up and over, with the understanding that in a morphology and an anatomy such as this, it's going to be very difficult or challenging to be able to cross from up and over, and you want to have a second access point, and this is where second access points work out. One of the things Vishal and I believe very strongly is that you cross from below, you treat from above. A lot of people have been crossing from below and treating from below, which I think in certain circumstances is appropriate, but in majority of the circumstances like this, when you have a solitary one healthy vessel down to the foot to put a sheath in and to do a pedal first approach may not be the right thing to do. Plus, I think having a sheath up and over allows you to have different modalities of therapy that you can use much more than below the knee. Second thing is you also want to look at what are the challenges you have anatomically about crossing. Besides the collateralization that you also have to understand that all these geniculate collaterals are going to supply the calf. So if you occlude these collaterals while you're doing the intervention, you may potentially make the patient worse. So go next, please.
PK, would you do different angles to see?
Yeah.
Okay.
Yes. So Vishal and I, that's what we've done. We've got the vertip catheter, and we've done different angles. And you'll see in one angle, as we're injecting, you start to see there's a stump that comes out, and then in another angle, you see there's the stump again, late that comes out, and then is there another one?
Yeah.
This one I don't know if you can play, right? No, you can't play that one.
Can't play
So let me go ahead and try to wire based on this. And so, I mean, Sardar, Vishal, Karthik, would you guys do anything different here? I mean, what's your approach been, Karthik?
I would. I mean, I don't know. Do you think there is a stump, PK? I don't know. What do you think?
Well, let's take a better picture.
Where we saw a stump, if you go 2 images back, there is
there's a delayed
we
filling.
see actually a stump.
Okay.
And that's the idea that you're not going to.
Before.
Well, I'm going to.
Yeah, he's live right now. See that?
Okay.
Well, we don't know. We'll see.
I don't know.
If you go to a different angle, to LAO, probably.
So my concern is the same concern as you gave, PK, right? Is if you destroy any of these collaterals or you cause spasm or dissection of any of these collaterals, when we are trying with a more significantly stiff-based wire, we might cause more harm than gain. So I mean, I don't see a stump here. I think there's more of a lesion in that bifurcation there. But if you, I think Sardar, I think it's worth giving it a try if you think. But I would have probably gone without a sheath, pedal access first, probably AT because PT is the dominant vessel, and then probably cross from below. That way you are safe, not destroying the collaterals.
Let's see. I mean, it's all right. There's no real right or wrong here.
See, that's your lesion, right? In that big genicular collateral. That's your lesion there.
Well, we don't know if this is a collateral or is this the actual pop. I'm not sure.
Huh.
We'll take a better look. We'll take a better look.
I think an LAO. Yeah.
We go to an AP view. This looks like a collateral to me. But I'm going to take this out. There we go. And I'm going to take another picture here.
So you popped into the other collateral now, it looks like.
Yeah, we might.
Yeah.
But I mean, we'll just, I mean, this is part of the trial and error that we're going to face, right? I mean, it's always, I mean, everybody is pedal first. And honestly,
No, I would not put a sheath or anything. I think you can easily cross without.
So the stump is actually behind it.
Yeah.
Yes, it is.
Yes,
Yeah.
right. It's between those two. No, not.
No,
Yeah, you're right.
Again.
Yep, I see it. It's going to be tough to get in. We'll get in.
I think this is a very good technique where you do live, means in action, inject and move your catheter at the same time to find the stump. You know, we are usually tended to just take a picture
give me a roadmap
DSA.
here, guys.
Roadmap. But it's good to try to so-called fish around like he's doing.
There's the stump.
Right
All right, now give me the wire. See, that stump comes off, and then you have, I don't even know if that looks like the stump to me. We'll see.
Okay.
We'll play around a little bit. But the point is well taken. I think that's what we want to make a point, that these collaterals are very important. And we all have the ultrasound machine. We're going to try this for a few minutes. And then we're going to go, we're going to let our ultrasound expert, Vishal, go ahead, get access, and then we'll go forward.
I always feel like, everybody wants to, when they say pedo, by default, everybody thinks you have to put a sheath in. I think we do it sheathless all the time. You can put an 014 catheter and go in and cross. Once you cross, you can work from above. I strongly believe that you have to do from both sides.
Yeah. Yeah, right, exactly.
So you think that's your stump, PK?
Yeah,
I think that's a stump.
And
Okay.
right on the right side, there is a collateral coming up.
Yeah.
I think, the stump doesn't look favorable from this approach.
Yeah.
If you apply the CTO peripheral algorithm, so probably.
PK, you want to take another picture, another angle picture? I don't know if this is actually a stump or is this just a bend in the collateral.
No, we'll take a.
This looks more like the superior genicular collateral, which comes in around the.
No, there's definitely a collateral off the stump, but it is a stump.
Yeah. Okay.
I'll take a better picture. Okay, give me some dye from above and below.
Oh, okay.
Okay,
Because this looks more like the meniscal artery.
Let me know when.
Oh, you're gonna have both.
Can
DSA.
you take this one, please?
1 second.
Yes. We're using a second wire now.
Okay, inject.
Yeah, just save it.
Injecting.
Thanks. We'll just put it here.
Now I'm gonna inject from below. The delayed injection. So that's not that. See, so you have the collateral coming off.
Yeah.
And then you have another stump right there that does it. So what I'm going to do here is, the best thing to do here is now get pedal.
Yeah.
And then track up before we do any sort of manipulation from above.
Yeah, it's probably
But I think it will likely would cross from above too. But I think that let's show this in two different angles, so this way it'll be fun. So Vishal,
you guys are going for the DP axis or the PT?
No, posterior tibia. So Vishal,
why not DP, PK?
Because DP is occluded proximally. I don't want to cross two occlusions to get through.
Okay, but I thought the TP trunk is also occluded, right?
No, it's just
the TP trunk is not occluded. It's just stenosed.
Yeah.
Okay.
So I mean, to cross two lesions doesn't make sense. Right. We're just going to put a sheath and we're going to cross. We're not a sheath. We're just going to put a support catheter and cross.
Yeah.
So Vishal, can you talk about your technique?
All right. So same thing. You PT.
Can you show the ultrasound, please?
You want to say
audiovisual team? We need to show the ultrasound.
Small bench, my friend.
Thank you. Okay, Vishal, talk about what. Or Karthik, maybe you can talk.
No. Sorry. Yeah.
I'll probably ask Sardar to comment on it. Can we make the gain a little bit less?
Yeah.
Or something.
Hold on. I'm to get you some gel right there. Okay. So here, can you see?
Ray, could you increase the gain, decrease the gain a little bit, or increase it?
We need to.
So here, if you see in the center, you can see the main artery and the two veins next to it.
Yeah.
So that's one of the veins collapsing, and the other vein is right underneath it.
Yeah.
So it's always, most of the time, like everybody will say, is like the anterior tibial usually comes in with two veins. So that's another way to identify a vessel. Pulsatility, here it's less pulsatile because we know it's a popliteal occlusion, so all the flow is collateral. So you might not see a good pulsatile flow in the artery, like to identify. The other thing you can do is do a color Doppler just to confirm. Let's see if color Doppler helps us by any chance. There you can see a flow right there. So that's those are some of the parameters to identify how an artery looks, degree of calcification. You know, sometimes even these arteries can be compressed because of the low flow, low pressure in them. You have a smaller, yeah. So
watch out, the needle's out.
Right. So same thing, ultrasound guided access right at the medium malleolar level.
No te mueva, señor. Don't move.
You can get the color off.
Color off there.
Sardar, you think you want to put any comments on this?
Actually, nice. It looks really good. Now you're just trying to get into the artery. I believe already punctured. So Vishal, I have a question which might be interesting for all people who use pedal access.
No.
Would you use the same cocktail, like the same vasodilatory cocktail, like for coronary artery?
Yeah, well, Vishal is doing this. Yeah, let me just comment on that. We do use the same
Vishal,
cocktail.
I think you're...
yeah. Okay. There's no... That's fine. Let's get the dilator in. There's no particular cocktail that's been tested here, Chief. But what we do is we always go ahead and use the same cocktail, and we give we go ahead, we use nipride rather than nitro.
Okay.
So again, there's no real approval or anything like that, or any trial that tells us which one's better than the other.
Wire.
But a lot of people wouldn't do what we do. Is that a sheet?
No, it's just a dilator.
So just pull out the wire.
Oh, yeah, that's true. Oh, yeah, give me the dilator.
What is that, the stiff command?
That's the fielder.
No,
give me a
command, please.
Oh, Spartacor, give me a Spartacor.
So what we do is, so now, Vishal, why don't you inject some cocktail?
Yeah, let's give some cocktail.
So we're going to inject the cocktail in. We're going to use some nipride. We're going to use verapamil.
So, Sardar, PK, you and Sardar, both questions. Like when you get pedal access, right?
What is this?
If you feel like that's the only vessel, Sardar, once you get the access, I'm pretty sure we'll cross this. You know, we know this, you know this, I know this. Once you cross it and you balloon and you get good flow, would you put the wire in that accessed vessel and just do a gentle inflation at the access site?
99% of the time.
Probably not.
Yeah, 99% of the time we just hold pressure. We did another perineal case the other day where our very own Dr. Reza helped us by holding pressure, and it closed automatically. I mean, all he did was hold light pressure over the perineal artery, and it worked out really well. Okay. All right, now let's get the support catheter, please.
Yeah, ready.
Okay, push that up a little more.
Yeah. So what support catheter are you using?
We generally, as you know very well, we generally go with the 018 Trailblazer. I know you like the angle Trailblazer. I like the straight Trailblazer. But I think, those variations are going to be different among operators. We go with an 018 catheter because we want the ability to go with an 018 wire if we need to. Generally, we don't need to, but you never know. And this being a live case, you want to be able to have all options available. And then why is he having some PVCs? Then we're going to go ahead and do this. He's had that forever.
The wire is not. I know.
Okay. Would you do anything different?
Actually, that's a very good approach.
Okay.
So the question.
So I think that makes sense.
Is now what wire would you start with from retrograde?
Well, so again,
Sardar.
Yeah. So what we're going to do is Vishal's going to advance this up. Once we advance this up, what we're going to do is I generally tend to inject through the Trailblazer, hold the wire right, and see the wire might have already crossed, but hold it. You can let it go. Let it go. I'll take a look. Okay, now it's okay. Hold it now. Don't let it go now. So what Vishal is going to do is take it up top. Sometimes you have a little bit of spasm. That's it. Stop there. You might have a little bit of trouble pushing. Yeah. And then so what we want to do is I'm going to have Haroon come on this side and give it a little dye. See, and it looks like the right spot. So I'm going to have Haroon come on this side. Vishal's going to rail me as I go up a little bit with the catheter. And now I'm going to take a little dye through the Trailblazer. Walk it out, Vishal. And Haroon's going to inject from above, and I'm going to inject from below. And we're going to be able to see our lesion and decide the wire. So I mean, Vishal, before we talk about what wires, what do you like to do? What's your algorithm? And then we'll go one by one. Hold on a second.
So I usually like to start with a little bit of hydrophilic, trying to find the micro channel if I can. I like you can use any wire. Some people like fielder, command, but I like the hydrophilic touch wire to begin with.
Yes.
And once we find the knob and we know we cannot do anything, we cannot cross it, then we switch over to a stiffer wire like a command to begin with, because a confianza, like a stiff headed wire. To cross the lesion. Most of the times they do work very well, but otherwise you have just escalated up to a higher level wire like Astaros and all that stuff. And that's why you have to, like PK said, get an 018 option, because if you want to use a heavier Astaro or a V18, then you're talking about the 18,000 wire, and that's where the micro catheter you don't have to exchange it for another micro catheter. So that's
so you can see here you have the trifurcation, and you can see here that the stump that we were thinking is the stump seems to be the stump. So what we're going to do is we're going to go from below, And the wire of choice, I guess I'll leave to you guys. But I already made my choice. But you guys go ahead.
Sardar,
Okay.
what do you do?
I mean, it looks amazing how nice you went up. So you are almost at the trifurcation. So and it looks actually not extremely favorable from retrograde as well.
No, it's
Therefore,
not,
the
yeah.
case is an extremely valuable case for teaching purposes. So I think important is not to create dissections if possible in the popliteal segment to get away with might get away without stenting this region. Is this correct, Dr. Krishnan? Would you?
Oh, that would 100% be the goal, Sardar.
Okay, I think Vishal, you did a great job. I think it was a very nice way of demonstrating the pedal axis clearly, especially when you don't have a pulsatile artery. I think it was great. I think PK, you are using a hydrophilic wire, if I'm not wrong, right?
No.
Oh,
We're going
you went with the
we're going
confianza?
Well, the reason we're going with the confianza is because you have a blunt tip.
Okay.
And when you have a blunt tip, we feel that the confianza is the best way to access this and go forward. So, you know.
That would have been my first choice too. I mean, Sardar.
Yeah.
I would have probably gone with that too, not a hydrophilic wire, but that's absolutely fine. That's what it is.
Let's take it. Now, what we want to do is you want it to be able to direct. You can see the confianza is making a bend, which is bad sign. Inject from above, right?
Yeah, injecting.
So you just want to see what this is, you know? And you want to try to see if there's something you can look at and get into. All right, so you really can't see anything. This is the challenge, like Sardar so nicely said. The challenge, hold that for real there for me, Vishal. Don't let it go forward. Don't let it go forward. Okay, very good. Okay, now get me the, this is when you might need a hydrophilic wire, like the Terumo.
To torque you into the microchannels, as Vishal was saying.
Well, you might want to do some blunt dissection here.
You
and
have,
yeah.
you'll end.
do
Okay.
a dissection,
Right?
re-entry kind of situation.
And what wire are you planning to use?
The gold.
Okay.
Terumo.
So it's a 018 wire, right, PK?
It is, but again, you can see here we're running into this calcified plaque that's not helping us.
Okay.
Okay.
PK, this is an angle catheter, or this is
Yeah,
a...
see, that's what I was going to say. That's why I think Sardar comes into play, and when he talks about using an angle and PK using a straight.
Okay.
See?
The angle catheter is honestly
Not an angle.
It's just something that just I think it gives you a sense of security. That's all.
Yeah.
You got to flush that, please.
That's true. That's true.
Give me a Fielder XT as well.
It's the same way as the difference between a cappuccino and a latte. More milk, less milk.
Oh,
really, right?
I guess this.
I guess PK goes with an espresso all the time. That too
Yeah,
double shot.
that's why he doesn't know.
So he doesn't know. So it's.
That's true, but you know what, guys? I as long as whatever you're comfortable with, I think for the audience back home is what's important.
Yeah.
You know, I really don't think like Vishal said, it's a cappuccino or a latte. It really doesn't make a difference. I mean, if you're comfortable with one thing, and we may switch, and there are times we do
this
switch.
is the command.
You know,
PK, I think Vishal, PK always tells me, when I was a fellow, he used to tell me, the catheter is as good as an operator. So
yeah, of course. No, I agree with that part.
And the wire also. It's not about the wire, it's about the operator. So
true.
Yeah, let's see now. Give me the Fielder XT.
Fielder XT.
So I want to go with the Fielder. We might try to do a blunt dissection.
So Sardar, let's say if the goal doesn't go, what would you do?
It's I mean, if the gold doesn't go, probably a Fielder XT would be a nice try, because there is probably a microchannel.
Okay.
Which we might, I guess I'm seeing a microchannel or like a small branch.
But it's sort of turning away, Sardar. That's the problem I'm having.
That's true.
So let's see how it does.
Would you do a blunt dissection and go, Sardar?
I mean,
worst
at
case.
the end, if nothing else works, this might be one of the last options for coming from retrograde.
Because PK, it's a good outflow, right? Yeah. The outflow is good. You have peroneal and posterior tibial, which are pretty robust, right? Yeah, I think even if you create a blunt dissection, I think it's still okay because you can do a DCB and still get away with it.
Yeah, that's the posterior tibial. No,
that's
I agree.
Your anterior tibial.
Yeah, so I got to be careful there. But I think the situation here is going to be we need to come from above and below. So why don't we try the other one now?
PK, if you keep the catheter at the cap.
Yep, I'm going up. I'm going up.
And
get a Fielder ready.
Yep, I'm going up.
And
let me have this one.
You think if you use an 014 wire to form a loop and get through,
Yeah, I
Well,
think.
we tried the loop there. It kept going into the anterior tibia and it kept
But you
going
used
into...
a gold, right?
No, that was a fielder XT.
That's a fielder.
That's a
Yeah, I
fielder
would probably use, like you said, probably use a command and try to loop it.
Yeah, a little
like
bit
worst
stiffer
case.
wire and see loop and see. Yeah.
Yeah,
And if it catches up the straight trajectory, then probably switch over and confianza, poke back in or something like that.
Yep, makes sense.
So you have a dissection plane there. You can see a dye
No,
staining.
not yet.
Give me
The
the
torque. Yeah.
Okay, guys.
Yeah, it just wants to go to this one spot.
Because there is a big collateral right there. I think it's
Correct.
going into that collateral. We just have to stir it away.
Yeah, it's easy. Yep.
Yeah, it has to catch up to that.
Okay.
So probably,
Give me a
yeah.
little die from below.
Mm-hmm.
All right, so I think this is when, after a little bit of attempts, we try from above and below. So let me get a roadmap.
Roadmap it is.
You know, PK, I hate to disagree with you, but I think Sardar's idea of having an angle catheter might work here.
I mean, listen. I mean, I don't think it's a question of agreeing or disagreeing. It's just different approaches for sure.
Yeah.
I think it's just completely different approaches. Makes total sense. But I think let's take a look and see how it goes. But either way, I don't think an angle catheter would have made a difference here. To me, it's the plaque, and you have a what is it called? A plane that's taking you to the other side. Let's see. So after this, what would your next step be? You mean we could try putting an angle catheter in, whatever, and then see whether we can go with another approach from above, which is what I may do here.
Yeah.
Let me see whether I can see. It seems to be getting in.
Into plane.
Ah! And now I don't know where I am here.
Yeah, you're in a plane,
you
PK. You might have to pull back and then pull back the catheter and then go in. I think you already formed a plane in the TP trunk. So
No,
No,
definitely not in the
He had
TP
good
trunk.
blood draw when we
Definitely not in the
aspirated
TP
back right now. So
Yeah. I'm just going to try to go this way.
Yeah.
Let's see now. Oh, see, it's doing the same thing again.
yeah, I think there's a the lesion right
Calcified
there
plaque.
is deflecting you off to that collateral.
Yep.
So then probably that's also like a blunt stump, another stump right there, so-called, which we're not able to visualize.
PK, I
because
know
of
you had
underfilling.
I know you had an angle there. You want to try that plane? I know you
We
went
may-
into
Well, we may try that in a second.
yeah. I know you had an angle there. It's not a most favorable angle, but I think it's worth giving it a shot
Yeah.
through that plane right there.
Yeah, we'll just try it. You're right. It's an 018 wire, no big deal.
Yeah.
All right, Ray, give me some above, some injection.
I mean,
just
it's not unlikely that popliteal can make that a mild bend, right? I mean,
Right.
it can.
Mm-hmm.
It can.
But it can. That's what I'm saying. So
See, there you go.
see it there.
But
So now it's going to
now
loop.
it's too much of a bend.
No.
Now, see, now it's a big loop. So yeah, that's. I mean, it could, but let's see. Let's see. Nope, not working.
Yeah,
So
it's
let me
going-
try from above. Give me a confianza from above. Above and below.
That's the confusion.
Yeah, that's
That's
not it. There you go. This is it, right?
I think this is
Positive.
That's the stump. It's just like the double lumen. We just have to
Yeah.
just catch on to that.
Okay, hold it there, Ray. Okay.
That's your confianza.
So we'll try from the confianza from above. And
Give me the-
sometimes when you have these
the
calcified
yellow
lesions,
torque
this is what works.
What do you need?
Torker. He needs it.
Let's see.
So,
Oven-
Sardar, what would you do if you're
Alright.
unable to cross from above
I
and below?
believe Dr. Krishnan's approach is very valid because very important is if you have such a tough lesion is not to be stubborn and stick with the primary axis you took. Is changing from one modality to another, like the kind of hybrid approach would make the success more likely and the frustration during the procedure less. So now the approach with an confianza from above is actually a very good one. Now he cracked into the stump.
Is he having pain?
Try to relax.
Same pain.
Yeah, pain, Mr. Morales? Any pain? No.
No pain. He just moved. Well, the problem is now where the question is, where are we? And
There.
no, it's
yeah.
not going.
Looks
That looks good.
looks good.
Yeah, looks good.
Okay.
Question is, would you change from an aqua tempo angled aqua tempo to a 018 catheter from
absolutely
above?
Yeah, absolutely. That's okay. I did it on purpose.
I'll make sure it's not stuck.
Okay, give me an 018 a Trailblazer. Let's get an angle this time.
Okay.
So I think your wire is
Yep,
so
it's
you might
shearing.
want to change. Yeah,
Yeah.
you might want to change the wire.
Yeah, once we get
after you put the.
Can you confidence, sir?
No, actually, give me a Turumo G.
G?
Gold. Oh, you call it Turumo G?
A gold tip.
Huh?
No, but that's from below, so we need another one.
What's our ACT?
484.
The micro catheter.
464.
Oh, there it is. There you go.
PK, would you try any other devices like crossing devices?
I mean, you definitely could. I mean, I know Sardar was talking about the crosser the other day. You definitely could try the crosser. But it's just a question of nice rail. It's just a question of what your experience is. In our experience, these kind of lesions, wire and catheter seem to work the best. So you can see we're heading in the right direction. It's not like we're in the wrong direction here. And so hopefully we'll get down there and we'll be able to cross. If not, it's also important to remember, like there's a short fem tip bypass. It's not a horrible situation for this guy. Let's take this wire out here. So it's not a horrible situation. Give me a Fielder XT first. So even
another
if we
fielder
fail,
that I trashed.
I mean, it's
Give me another fielder.
no harm, no foul. I mean,
trashed the fielder.
I'd much rather send him for a short fem tip bypass, make him feel better with a small vein. He's got a healthy superficial femoral artery. He's got a healthy tibial, posterior tibial. So to go ahead and do a quick bypass, it's nothing wrong with it. I mean, I think a lot of times interventionalists feel that they have to cross every lesion, and sometimes you can do more harm by doing that. But let's see.
Vishal, we have a question for you, which was just emailed. They're asking, can you explain where you puncture at the retrograde axis site when you take the PT?
So I mean, it's just multiple factors. You don't want to try to go high up. So one is the artery itself. If there is calcification, try to hit the non-calcified spot, mostly at the medial malleolar side, just behind it. You don't want to be too higher up because then even though the vessel size becomes bigger, it just dips deeper in. So the sweet spot is where the calcification is the least, behind the medial malleolar side. And then if you can't get it, or there's a lesion or a CTO, then you try to advance and go more proximally up. But you try to go as higher up as much as possible. So that's where you usually try to do it. Oh, yeah.
So the problem here is exactly what we're dealing with, which now the catheter is not going. So we might have to go with the coronary teleport or something like that. This is the problem with these bulky Trailblazers. Give us a teleport, guys. So, and this is where often I tell Elizabeth to turn off the ACT, because Angiomax. So I'm just going to walk this back, keep it there. And then
You're
go
pretty
with
close. So.
Go ahead, walk it back.
Yeah, still not out.
ACT was 400. And
No, just one moment.
So in the meantime, while they play from above, we'll try playing from below.
So PK, you're switching the Angiomax off because you're worried about a perf, or?
Yeah, I always do that. I mean, to me, people are different. I mean, to me, it's like, when you're going with an Angiomax or whatever, it's better to, it's not that it's out of the body. Maybe I'm making myself feel better. But to me, I just turn it off at this stage and try to go down.
Okay.
So
when you're doing lesions like this, PK, you want to keep the ACT on the higher side. I mean, we are doing Angiomax, but let's say if people are doing with heparin, which most of them do, would you keep the ACTs on the low 200s or high, or?
I mean, to me, it's a question of your comfort level and the size of the equipment you're using. To us, I mean, we're using very, very small wires here and very, very small catheters. So
what would you do?
So I mean, the advantages with heparin is always you can reverse it, but the huge disadvantage is that you have to recheck the ACT every now and then. And since endovascular procedures are frequently very time-consuming, and like in a CTO situation, you might forget about adapting your heparin. Angiomax is actually easier to handle, but the drawback is that
it's right
you
at the
cannot antagonize it
at the
in case you
synovial.
have any horrible perforation or bleeding condition. But we do here more frequently angiomax for infrainguinal interventions, and we actually had a good experience until now, right?
That is going to share.
Vishal, how would you maintain your ACTs? Because it's important, because we are dealing with a blunt stump. You can perf. If that's if that's not what your stump is, then there's a good chance of perfing when you cross it. So what would you would keep it low, or?
No, I mean, most of the times here we use angiomax, which is what I prefer, because like Sardar said, longer duration of procedure, so it's better. And right now at this stage, let's say we perf, it's more of a wire perf. So wire perf still preferably, hopefully, it's not going to cause so much damage as if we would perf after an atherectomy or a balloon or something else. So I would not be, stopping the angiomax is good, because remember, angiomax will still be active for another 20 minutes, even if it's you stop it. So the anticoagulation still proceeds. So I usually like to keep it anticoagulated. With heparin, probably 300 is a good number.
Right. Okay.
And
so I think, PK, what you're trying to do is connect the wires from below and above, so that you can find the plane from below.
We're unable to go from above with even with the small catheter.
Right.
So therefore, we're going with a fielder, and I'm going to try to wire it close.
PK, you're comfortable that you're in the stump, right?
I'm definitely comfortable we're in the stump.
Okay, so if you think you're comfortable, you're in a stump, would you take like an 014 balloon? Try to just balloon at the level of the stump and create like a plane for yourselves to get the catheter down?
No question. We will
like a coronary balloon or something like that,
No question. We will do that for sure.
Yeah.
I would just loop it from here.
So now you can see we're both close. Let's see here how this wire goes. It's just dissecting up.
Yeah, I think it's still okay, right?
Yeah, no, it's okay. We're fine here.
Yeah.
Let me just...
I think you're in two different planes, which is fine, I guess. I mean, you can take any plane which crosses.
Let's see if the wire interacts.
Yeah.
Yeah. Yeah.
I think you're in the lower segment.
Now we're through. See?
Yeah, we're through.
We're through.
Wonderful.
Real.
Hold on, 1 second. 1 second. Good.
So you were in the right plane. You could have.
So yeah, that's where now Karthik, being sheethless, it just becomes a bit harder to push, but we can still do it. But you're right, we're through.
Hold that there just in case.
So now we need we need Ray's magic. Hold on.
You want to take a picture and see, PK, first?
No, don't push.
I don't want to push.
Don't push, because it looks like you're still in a small plane there.
No, it looked.
I don't think I don't know if you're really in. So
no, we're not in. We got to pull back, Vishal. Pull back your wire.
Yeah, I don't know if you're in because the way your wire behaved.
Yeah.
Pull back
You want to make the wire back smaller.
Pull the wire.
I think you'll pop in if you make the wire smaller.
Yeah.
Now try. No, you're not in. Okay, let's.
I got to exchange my wire to.
Hold on, let's just stop there for a second.
At least it'll tell you where the stump is,
right?
If you're in the right plane or not. So, if you pull the catheter back, and now take a picture, I guess.
Okay, hold on. Give me a confianza now. Yeah, watch this out. Leave that there.
Come on, walk this out.
PK, you want to see where it's entering?
We're gonna take a picture. We're definitely gonna take a picture.
I want to change this wire. This is trash. I probably might not.
I just want to hold this while you pull it out. Pull it out. Pull it out. Yank.
Yeah.
There you go. Okay. So now what we're going to do is we're going to go to different angles.
Now we use it to remove.
I may actually have to pull the catheter back, which is fine.
Or you can actually balloon from below and then enter into that plane from above. So
I don't want to knock off the collaterals.
Yeah.
Ready, DSA?
Yes, sir. Hold on.
But if you balloon from below, you think you're going to knock off the collaterals, PK?
Absolutely, because if I'm in a plane, I may plow shut the vessel. See? So I got to pull back a little bit and then go the other way. Okay. Give me. Let me go.
I'll probably switch over for a Turmo Gold here now.
Hey, give me a Confianza first. Actually, gold is fine too.
Yeah.
I like both.
Can I have another gold?
We open the gold, right?
We have one, right? This is it. Yeah, right here. Right
You
here.
never opened.
Here. It's okay,
Dye, please. Contrast,
Another
please.
gold.
No contrast anymore.
When you shoot from the
Yeah,
left.
that's another gold.
Yeah, you can do that.
This is trash. Here, this is a gold.
Oh, the catheters. No, you can't see anything.
Yeah.
There's no flow. It's okay. We'll shoot from this. The catheter is so small. We might have broken into the vein. It's happened to us a few times. So, we've done that too. Because it was so calcified that we might have broken into the vein. So I wouldn't be surprised if we're in the vein.
I mean, you can pull back blood and see if you are. I mean, you will know from the catheter below. You can always give a little bit of injection and see.
No, I don't believe in that. Never give injection from below, especially when you're in a plane. It totally obscures your ability to do anything different.
See if maybe it popped through.
Yeah, we're in the vein. There it is. Okay, we're through.
Yeah. There you go.
Yep. So save that, guys.
Off floor.
Yep.
Hold on.
Rail now. Let me push it up. Now do not
So-
pull this wire back.
Hold on. Hold on.
Ready?
Let me give you a real. Okay.
Don't pull the wire back.
I am not pulling my wire back.
All right. So now
So PK,
we're-
that's what I was trying to say, right? I didn't know if I
Go
really don't know
together.
if that
That's
was the
best.
stump for you.
that was 100% the stump. What are
You
you
think
talking
so?
about? We crossed right there. Come on.
You think
Come
so?
on.
Okay.
Absolutely.
All right. I still don't agree, but that's fine. I mean,
Can we
if you
please
think
get
so.
Karthik some glasses? All right.
I know. I didn't wear my lens today, this morning, but
All right.
absolutely
We already
right.
have blood coming out, so
Now
it's
give
okay.
me-
I didn't
now
feel
give
like
me
that was, but
a
that's
catheter.
totally fine.
Gooch, come on.
Oh, that's fine.
I know you
Okay.
hate being wrong, but come on.
No.
my
I can totally be wrong. It's totally fine.
No, I'm like you. I hate being wrong too. That's why we get
No,
along.
I didn't feel like it was the stuff.
That's why we
No,
both get
no.
along. We both. I speak to your lovely wife all the time. She says, start the max. She says that you hate being wrong,
No.
but she says the only reason she loves you is you admit that she's smarter than you.
Come down. It's in the branch.
Oh, she is though.
Okay. Please start the max.
I want to live in the house, so
Pull it back and
Yeah.
make it go the other way.
Get right ass.
So let's see.
Right. Let's see what's going on. For French.
So Vishal is really trying to. Yeah, thank God.
My lord.
My Lord, Vishal. Bird tip catheter. So I mean, I think it teaches that what we're going to do is you want to go ahead and.
PK,
And
you want a balloon from below and then get into the plane?
No,
or-
he's going to play the game. Marry one into the other.
I know we don't believe in doing anything from below. Me and Vishal are pretty strict. Little dye guys here.
You need the snare.
Can I have a wire?
Snare.
No, I don't need it.
Now he'll try
Can
to.
I go?
Is she gonna
So
try?
Vishal is a master at this. So we'll. Actually, we should use another wire, huh? You would.
No, this one-
you want to use this particore? Back up
Yeah.
here. So hopefully we can. Yep.
Enter.
We're able to torque it in. Just slight movements. There you go. You had it. This is like watching paint dry.
I know, right? Probably coming down and doing it a little
Yeah,
bit better because
smaller
it's too big
lumen.
of a vessel.
Sounds
Exactly.
good.
Usually it's better to do it more distally,
We'll go wherever you guys want.
but not too crazy.
Right there.
That's probably a good way, good position.
We always put it up against the wall.
Okay, let's try.
Hmm.
There.
There.
So maybe you're right. Maybe another.
So maybe
Yeah.
One.
maybe you want to go with a fielder or something?
Yeah.
Something better.
Spartacle.
Spartacle may be tough.
Yeah,
Just
give me a
him
fielder.
guys. Let me just push this up further
Yeah.
to make sure you're safe.
Mm-hmm.
So you want to get this catheter as high up as you can, so you're out
PK,
of the,
can't you get both the catheters close to
Catheter,
each
yeah,
other
that
and then
was-
wire?
You can
Yeah.
do that. Yeah,
That'll
let's
give
do
us
that.
more support and
But I
direction.
wanted to show everybody Vishal's wiring skills. Listen, you can't blame a guy for trying, right?
Vishal didn't have his coffee this morning, so
Exactly.
Oh
his
my
hands are
God.
shaking. Can we help him out a little bit?
Blame it on the coffee.
If it wasn't for my access, Karthik,
Actually, honestly,
I know
the,
that's true, Vishal. I can agree
Hey.
with that.
Actually,
That was a great job.
the best person for this is Reza. Reza is our CTO expert here in the coronary fellowship, and he loves CTOs. He would cross this in a second. Let's go right in, right in. Come on, Michelle, bye. All right, give him a fielder, guys.
And what about the option to snare it?
Of course we could snare
Would be
it.
easier. Would be
Yeah,
easier
of
for
course.
everyone.
But listen, we want to show everybody, different ways. It's expense, right?
Maybe catheter to catheter.
That's what Ray's trying here. But of course, I didn't have an angle catheter right here. This view. If I had an angle, see again, Sardar rubbing it in. I don't have the angle catheter.
PK, I just wanted to ask Vishal, PK, and Sardar. I mean, why can't you just put an 014 wire, right? Balloon it with a 3O balloon from below, and get from above. I mean, it's probably the cheapest and the fastest.
No, but you have to understand, you're putting every balloon is 4 French, right? So you're putting a 4 French shaft, every balloon, including a coronary balloon.
No, it goes through a 4 French, but it's actually 2.7, right?
But
so
why
technically,
it's compared to
almost like an
018
it's like an 018 catheter.
No, absolutely not. To me, you also when you go sheathless in the foot, you're going to shear the vessel, right?
Mm-hmm.
Oh, sorry, you're going to shear. There it is. Hey! Oh, I was celebrating too early. Haroon just kicked me. Ready?
Put a 2.4 French of Cook, and then
if that was my
balloon.
I totally agree. But if it was my posterior tibial, I wouldn't want it.
Okay.
I've got to be honest with you.
That's fine. Sardar, what do you think?
I mean,
Sardar wants to snare it.
I would snare it in a heartbeat. I totally agree. But again,
and Sardar thinks you should have used the angle catheter.
No, one thing you want to do is you want to point it against the wall. See, like that. So one wall or the other.
PK Sardar keeps whispering in my ear saying that you have to. PK should have used the angle catheter.
I'm not saying anything.
There. No, you're not. The best thing. The best thing about Sardar is now when we get to the office, I'm gonna hear it all day. I told you to use the 018.
No.
I told you.
Definitely
You don't
not,
listen.
definitely
You don't listen. That's the thing. All right, let's get the snare. We got to show everybody how to use the snare. Vishal Bhai, unfortunately, you don't get the award this year. Vishal did an amazing job. Everybody at home, we're just teasing Vishal. He's the amazing interventionist. All right, let's go.
Chance.
Last chance. Snare's open. All right, so Haroon, we talked about how to use a snare. So the key to using a snare, guys, is first you need to get a woolly wire down. So let me get a woolly wire while Vishal keeps trying.
Yeah, no, it's totally true.
Okay, PK, I think when you're putting it down, I think Sardar, you want to just go over the snare? How we do the snare? What kind of snare? Sizes of the snare?
So we use the. Sorry.
No, I'm just asking him what size snare he gave us. He gave us a 5. Okay. Go ahead, Sardar.
Okay, so you're gonna put the woolly wire first in?
Yep. Mm-hmm.
Yes, exactly. All right. So then exchange the catheter out.
Then put the snare catheter in.
Yes.
Right.
And what size of snare are we using?
5. Liz?
5.
I got a little splash on the side of my eyes.
Yeah. Right.
Did we turn on back the ACT or not?
Yeah.
I mean the Angiomax?
It's probably in the eyes.
Okay, so we're using a 5 snare.
Oh, okay, something.
Sardar, do you make any bend on the wire or anything like that? Or
on the side?
Actually, not. I mean, on the distal wire. Probably there is a bend already. Once they went in, but I think a small curve might be enough.
Right.
And just wipe the whole eye.
It just need to be more space from the catheter to the tip of the wire, so that you have more space to catch it.
So Mom Liz took care of my little splash that I had, and so we're gonna go down here. So this is we take it down here, then we pull the wire out. Now Reza is gonna give me the snare.
Introducer, yeah.
And the snare has a little introducer, folks, and I think it's important that you see that the introducer is there when you go in.
Okay,
push the introducer down.
Yeah.
So the introducer goes in. So as the introducer goes in now,
push the wire.
Right. So we're going to push the snare in like a wire, and then when I push the introducer back, Haroon or Vishal is going to undo the back of the snare and take out the introducer, and then redo it.
So unscrew it.
So it's like an unscrew thing.
Yeah.
Right. That's it. No, you did it wrong.
No,
it's okay. Okay. So the snare will pop out. And the way we do it here is very simple. We have Vishal generally wire the snare, or we try to just catch it like that. We might have caught it already. So, Vishal will put that back. And what you do is, thank you, Vishal, bye. What you do is you fix the wire, and you advance the catheter. See? And you capture it. See, we got it. See?
Yeah. And you pull everything in.
So now Vishal will push the wire.
You're losing it.
One second.
Hold on.
Yeah, hold on.
Push the wire up, Vishal. Vishal will push the wire up so I get on the stiff part of the wire like that.
Okay. Yeah, so.
Okay, now I got it.
That's
Laura?
better.
Yeah.
Now push the wire, Vishal.
Yeah.
Key here is, guys, you have to have your partner push the wire. Oh, it slipped. Show me above.
Yeah.
You have to have your partner slip the wire.
Okay, you want to track the wire into the
catheter.
catheter first, right?
Yeah, exactly.
Let me see.
You want to
Show me
track the
above.
wire into the
Yeah.
catheter first?
Yeah.
No, we're still good. Let's go. Push Vishal.
Okay.
The key is Vishal has, and see the violent movement of your sheath. So Ray's fixing the sheath to reduce the iliacs. You're good?
Yeah.
Okay, it's out. So Ray's fixing the sheath to reduce the iliac stress. And now what Vishal is going to do is keep pushing the wire.
Yeah. And I'm gonna give me
and
a
I'm
clamp.
just going to gently pull by fixing the sheath. There's a lot. Okay, now what I would do, Vishal, is walk that catheter out. Just pull it out, yank it out. So now Reza was kind enough yesterday to hold pressure. Might hold pressure again if it bleeds quite a bit. Which
give me
it
the
is.
mosquito.
Ready?
Right.
So this is the issue here, Karthik. This is the shear I was talking about, because now Vishal doesn't push, I'm shearing the artery. So I never pull till I feel laxicity. Push, Vishal.
So the only thing I do different is I put a micro dilator down, so that way you have the transition zone of entry zone of the artery, and you don't really shear it.
See, there's no shear there. See that?
Yeah,
so
short
smooth.
bites.
Okay, so now we can go with a coronary balloon. It's enough. We'll cut the wire here, right here. So give us a 3/0 coronary balloon from above.
Okay, why don't you just put a regular over the wire balloon so that you can just change the wire, right, to a Spartacore wire.
Okay.
Cross it, change the wire into the Spartacore wire, and then just take the wire out of the vessel.
We could. What I know, see, the reason I'm not thinking is I don't have enough purchase of wire here. Can I have a regular 3/0?
But
it doesn't matter.
But you have a safari technique, right? You can hold it there and you can just keep pulling the wire.
No.
The balloon.
No, I understand, but the balloon could bend. That's the point.
Yeah.
So what I'm saying is I completely
no, but
agree
I
with
think,
that.
but you're over the two ends, right? So I think you will have a lot of control over the balloon.
I'll give you more
you're
purchase.
over the two ends if you have both wires out. But the point is here, the balloon is going to go without a wire. But that's okay. I understand your point.
Yeah.
Flush it, please.
I mean, it's just that you can take this wire out. You don't have to keep this wire through and through the
outside the
like
vessel.
No, it's okay. We definitely will take it out, 100%. Okay, rail, please. Just keep
I always feel like
guys.
the faster you take off your access point catheter and the sheath, the better it is. The less amount of time you keep something in that vessel, the better it is. You agree?
I agree too.
I'll feed you more wire if you want. I have more wire.
We have the wire now. Okay.
Beautiful.
Okay. Rail the wire, please.
So the question now after crossing,
you want to go a little bit lower and change the wire a little bit lower? More lower. Yeah, that's good.
You can go all the way down.
I think you're good. Now you can change it to a Spartacore wire, which is less traumatic. You would probably pull from above, right?
Yeah, pull from. I'm going to push. No, I want
to. To me, it honestly does not matter.
Oh, okay.
You can pull from above or below. It doesn't matter.
I feel like you have less wire outside on this end now.
Yeah, I agree.
So it's easy to just.
Yeah, but the wire is protected on the above, right?
Get a Spartacore.
Because it's through the.
Okay, good.
Get us a Spartacore wire. Yeah.
So that's why I was telling PK, like, when you work like these CTOs, a lot of people do from below, a lot of people do from above. I think when you combine both, and as soon as you get to the distal vessel, I think just taking off your access point equipment is probably the best thing to do. I think the less amount of time you keep an equipment in the tibial vessels, that's what I feel is the more reason for the patency of that vessel. It causes less spasm, less injury.
No, I don't agree, because if you have a wire in it causes no spasm at all. It's a large vessel. If you have a sheath, then I completely agree. I think for a wire, I mean, it's not an issue at all. Okay, good. Let's go up here, guys. I'm going to pull it back.
That's good.
Let's go up right. No, I'm going to come back.
Just
Right
there.
there. Let's start here.
Oh, you don't want to balloon the TP trunk, or?
No, I don't want to lose my AT, right? I think what I want to do is let me try to preserve everything if I can, and then take a picture and then decide. So again, it's 9 o'clock. So for the audience, what we're going to do now is we're going to balloon this, and then we're going to take a picture. Go up, yeah. We're going to take a picture.
What balloon is this, PK? 3O balloon?
3O Abbott balloon.
Okay.
6, 8, 10. Down.
So Sardar, what would be your post ballooning options? What would you do?
I mean, I'm trained in this institution, so I would like to do an atherectomy and modify the plaque a little bit and to.
Even though you think the popliteal is just a dissection plane, you would still atherectomize it, or?
If I'm definitely sure that I'm in a dissection plane, probably not, but it looks actually good in this picture now. So atherectomy might be an option.
Okay.
Followed by drug-coated balloon technology to keep the patency.
Right.
Okay.
There.
Go up here.
I guess that's a good option because otherwise you will end up implanting a scaffold.
Right.
And with leaving metal in this segment, you might take the chances for a future bypass surgery.
But the problem, Sardar, like they're never going to bypass to this occluded segment anyway. Go up again.
Yeah. Right. They would probably bypass to the PT.
Right.
Yeah.
So as long as you don't muck up the PT, you're okay.
Yeah.
But I agree with you. I would go with the DCB, an atherectomy possibly after this picture, and then take a look down. Let's see.
Vishal, what would you do?
I would stent it. I would probably use a Supera. I would probably use a Supera.
But how would you deal with the Vishal, the stent mismatch? That's my question to you.
Yeah, I mean, we just have to balloon dilate the distal segment. You'll have a step down at the AT, but you have to dilate your distal. Because if you're putting a scaffold, then you don't care about dissection. Then I'll probably use a 5.0 or he's a male, so you probably even use a 6.0 balloon, put a 5.5 Supera. Yeah. And there will be a step down, that's for sure, but I'll still take it till the time there is no damage to the AT or the PT circulation.
Nice.
Robust.
Very nice.
Okay, so let's go ahead, and I think I want to use a 5.0 DCB. Let's do a 5.0 DCB.
We're not doing atherectomy.
So,
PK, why did you want to do atherectomy? Like any particular reason? Or?
I mean, you could. I mean, to me here, you can definitely do atherectomy, but I agree with you that the plane is quite dissected and it's a popliteal, so I think a DCB is good.
Okay. Okay.
5.0 long. Because we're going to go
I guess Harun has a couple of slides for as an
so
overview
Harun, why don't you go over some slides for everybody at home? We finished the technical aspect of it. Harun is going to talk about popliteal treatment. 5.0 80 or 80 DCB?
Yeah.
Actually, give me a 5.0
Could you
Slides,
put up the slides for me, please?
Yeah, sure. Come.
Next slide, please.
Just a slide pressure. Yeah. Perfect. Sorry.
Okay, so let me just go through some of the challenges of the popliteal artery intervention. Popliteal artery is embryologically distinct from aspirate due to its origin from sciatic system.
120.
It is subject to significant biomechanical torsion forces.
I think I'm going to stent
the repetitive knee flexion extension.
Maybe not, we'll see.
Consequently, it affects patency rates associated with popliteal artery bypass or endovascular stenting. In that, biomechanical stress can lead to stent fractures. Moreover, it also supplies important communication above and below the knee through the sural and the genicular branches that can serve as important collateral in case of occlusions. So intervention this side via surgical endovascular intervention can compromise these branches and turn a CLI to an acute limb ischemia. Next slide. So in terms of the appropriateness, ACCHA, SCI, and SVM in 2019 came up with the appropriateness use criteria that suggests that the endovascular and surgical intervention are equally appropriate in patients with CLI, as depicted in the figure on the left. Next slide, please. Next. So once the lesion is successfully crossed, in terms of the vessel prep and endovascular intervention, we have multiple options in this territory. That includes a PTA alone, PTA versus DCB, PTA with stenting, or a DART therapy that includes the directional atherectomy and drug-coated balloon technology. Next. So in terms of the different trials that have been done on the popliteal artery, let me just talk about the Biolux P1 trial. This was the DCB versus PTA trial. This was a prospective international multi-center randomized clinical trial. There was a 1-to-1 randomizations. 60 patients from 5 European centers were included. and DCB was compared with the PTA.
This is good. We're below.
The restenotic lesion were greater than 70% and 30 to 200 millimeters in the SFA and prox-pop artery were studied. Late lumen loss was 0.51 versus 1.04 in favor of DCB at 6 months. Binary restenosis was 11.5 versus 34.6%, also in favor of DCB at 6 months. Clinically driven TLR for intention to treat was 15.4% versus 41.7% for DCB at 1 year. This was borderline significant. Clinically driven TLR was 6% versus 52.9% significant for the S-treated population favor of DCB. Improvement of at least one Rutherford category was seen in 72% of the DCB patients versus 65.2% of the balloon angioplasty patients.
3 minutes.
Next. So the next trial I want to talk about is the Illuminati trial. This was a DCB prospective single-arm multi-center trial. 50 patients with 58 lesions were enrolled. Mean lesion length was 7.2 centimeters. And baseline stenosis was 75.1%. 62% of the lesions were calcified and 12% were occluded. Major adverse event rate was 4% and the mean late lumen loss was 0.54 millimeters at 6 months. Primary patency rate was in 9% at 12 months and 80% at 24 months. Freedom from clinically driven TLR was 90% at 12 months and 85.8% at 24 months. So pretty significant results for the DCB. There were no amputations or cardiovascular deaths reported at a follow-up of 2 years. Next. Next, I want to talk about the MDT SFA Japan trial. So this was a DCB versus PTA comparison, independently adjudicated, prospective, multicenter, randomized, single-blinded trial. 100 patients assigned by 2-to-1 randomization to Impact Admiral, 68 in the DCB and 32 in the PTA. Symptomatic de novo restenotic lesions in the SFA or proximal popliteal artery were studied. Mean lesion length was 9.15 and 8.89 for DCB versus PTA respectively. Primary patency was 79.8% versus 46.9% in favor of DCB at 24 months. Clinically driven TLR was 9.1% versus 20.7% for DCB versus PTA at 24 months. This was not statistically significant. There were no device or procedure-related death, major amputation, or thrombosis in either group. Next. So the next trial is the ETAP study. This was a prospective multi-center randomized clinical trial. 246 patients were 1-to-1 randomized to either a nitinol stent versus balloon angioplasty. Mean lesion length here was 42.3 millimeters. Primary patency rate was 64.2% versus 31.3% for BMS versus PTA at 24 months. TLR was 22.4% versus 59.5% in favor of bare metal stent 24 months. Secondary patency rate was 78.3 versus 77.8% for BMS versus PTA, no difference. Incidence of stent fracture was 4.6%. Significant improvement in API and other categories was observed at 2 years. Next.
Double negative.
Next, I want to talk about the superapopliteal artery stent registry. This was a retrospective registry data review at a single center, 101 patients with 125 stents at the popliteal artery were followed for 12 months and with ultrasound, X-ray, and clinically with the Rutherford category evaluation and ABI. A less than 30% residual stenosis was achieved in 98% of the procedures. Primary patency was 94.6% and 87.7% at 6 and 12 months. Secondary patency rates were 97.9 and 96.5 at 6 and 12 months respectively. Mean ABI improved from 0.58 to 0.97.
Perfect.
Mean Rutherford category decreased from 3.1 to 1.4, statistically significant.
Looks like it's
No incidence of stent fractures was observed at 15.2 months.
Look at the distal end of the wall.
Next.
Okay, ready when you are.
So next, I want to talk about the DART therapy versus the DCB. This was done by the Dr. Constantino's group. It's a single center study comparing DCB, 31 patients versus DART therapy in 41 patients. Intervention of isolated popliteal artery stenotic disease was studied. Mean lesion length was 47 millimeters versus 42 millimeters respectively. Primary patency was 65% versus 82% in favor of DART therapy.
What, 80?
80.
Freedom from TLR was 82% for DCB versus 94% for the DART therapy. Secondary patency was 96% for both groups. Bailout stenting was higher with the DCB, whereas aneurysmal formation was higher with the directional atherectomy DCB. but there was no statistically significant difference. Distal embolization rates were similar for both groups, 3% versus 5%. Next.
Look at the wire end. Just want to make sure my wire is.
So in conclusion, popliteal artery CTO intervention remains a challenging entity due to its anatomic location. Both surgical and endovascular revascularization strategies are appropriate and equally effective in treating these lesions.
Still bleeding?
PTA alone achieves as well as 65% patency rates at 1 year. DCB is found to be, based on the trials that we just went through, superior to PTA alone.
Yeah.
Directional atherectomy appears to be more suitable for high-risk lesions, which are such as calcific, long lesions, and resistant restenotic lesions. Stents offer improved patency at the expense of risk of stent fracture, thrombosis, and compromise of future surgical options. Thus, in my opinion, stenting should be reserved for bailout and flow-limiting dissection.
You're at 24 at the end of the screen.
30%, and recoil. Thank you so much.
Nice presentation, Haroon. So
I think it was great.
Great.
That was a good overview.
Very
Thank
good
you.
job. Yeah.
So we're just going to show you the picture we have here. So he's going to go to 10 with his balloon. So once he's up with this 3.0 balloon, we'll take a look. Now I want to show you. So we did a drug-coated balloon after a quick atherectomy, and what we saw here, as you can see, is you have a little dissection right there that may be flow limiting, but then you have some tight lesions. So what I did was Vishal and I decided to take the 3.0 balloon down across the posterior tibial and do a balloon angioplasty. So we're going to do a nice 2-minute balloon angioplasty and then take a picture. So it's 9:05. So again, it's a case that is a well planned out case that really shows how you can do complex cases within an hour. So obviously I've got the star team here, but regardless, you can definitely do it within an hour if you plan it properly, anticipating the complications or the I should say not complications, the challenges. The issue here is what's our final therapy. So let me ask Haroon. Haroon, you know the data better than anybody here. What is the story in terms of what is the best option for this particular patient if we have no flow limiting dissection and we have reasonable flow?
So in my opinion, if you can get away with a drug-coated balloon alone without deploying a stent, leave no metal behind would be the best option.
So what is the disadvantage of doing a Supera? You just presented tremendous data with Supera that showed fantastic results in this particular area. In your idea, what is the disadvantage?
So I mean, the only problem I see with the Supera is that has to have a very good vessel prep, and then the deployment is a little challenging because of the too much elongation and too much compression can lead to worsening or restenosis.
And also the fact that you're going to have a step down here, which Vishal talked about, may be the issue. So okay, down. We're going to walk this back, and we're going to take another picture. We're not going to give night priority as a low EF, so you might not have been a bad bypass candidate. I was reminded gently by Ray. Ready? DSA? Inject.
Tremendous.
Wow.
Tremendous. But
so again, when you look at this, guys, see, I think it's important for everybody at home to understand those collaterals that you see are incredibly important. And you've not knocked off anything here. I'm just letting Vishal walk it out. So right now, there's no blood going on. We're going to take 2 views. And the question is, let's take another view before we pull the wire back. And I think I know Karthik is going to say, let's stop. I don't know about you, Sardar, inject, and Vishal, but let's see. Just don't like that distal pop into the TPT. Whether we should stent that, I don't know.
I would stop, PK.
You would stop with that?
Yeah, I would stop.
But don't you think there's a little recoil going on there, Karthik?
There is a little recoil. I think you have to come back for the AT also. If you want this popliteal to stay without stenting, you have to get that AT open with a good outflow. I think probably I would stop at this point, give it some time, bring him back after a month. Do an ultrasound, bring him back after a month.
I think we had to balloon that at posterior tibial as well.
Yeah, so, the whole segment from the TP trunk down to the posterior tibial, you just have to balloon. But that AT is a pretty reasonable size AT. If you get that AT open, which is not that difficult, looks like, because it's subtotaled.
give us a 4.0 long balloon. 4.0.
Well, I mean, because
I
the
think
issue
this
is your-
popliteal will stay open even without stenting at all. I think you'll have very good long-term patency because it's a very good outflow.
Yeah, I think Vishal and I just talked and he agrees. So I think I just want to end this case. It's 9:10. So as far as a couple of questions, first to Sardar, and then we'll end with Vishal's opinion. 40, no, 40, no, not 200.
No,
40,
sure. Like 100.
100. So Sardar, anticoagulation for this patient.
I mean, here we can apply actually the Voyager trial strategy. We did an intervention. We can put the patient for a certain time on dual antiplatelet therapy plus a low dose rivaroxaban therapy with 2.5 BID. And after 3 months, we can interrupt the Plavix, the clopidogrel therapy, and continue with the dual therapy for a little bit longer term period.
What about you, Karthik?
Yeah, I would probably just put aspirin Plavix speaking. I don't
Really?
think. I would not. I mean, I don't see. I don't know. It's hard to say. I think the cardiomyopathy patient. I would. You can go either ways. I think from my standpoint, I would probably just leave the patient on aspirin Plavix. I think the more important patient for this is to keep a surveillance after a month. I would probably do an ultrasound after a month, see how the patient is doing, how the vessel looks, probably get the outflow. That's probably more important to me than anticoagulation at this point of time. I think you have a great result. I mean, this is a fantastic result. For that CTO,
yourself?
I think this is a great result.
No, I've become a believer of Xarelto, so I'll definitely put this patient on dual antiplatelet therapy, but low dose Xarelto, 2.5 BID.
A little more.
I would, in this case, young guy, low risk factors. I would probably
Slowly to profile.
be aggressive on the anticoagulation strategy for him from a medical standpoint.
So for everybody at home, you can imagine the the controversy with anticoagulation that's going on currently. And even though our recommendations and our guidelines are very clear, I still think that learning to apply the relevant data is very, very important as well. Just go to profile, guys.
PK, I know for us, it's I mean, in America, Xarelto is covered by a lot of insurance companies, but 2.5 Xarelto is not cheap. I mean, I'm in private practice. I can tell you that. A lot of my patients come back and say it's not cheap. They have to get a lot of out-of-pocket costs. So. I mean, from our standpoint in Sinai, it might be easy to say, but all around the world, I think there should be very diligent use of Xarelto 2.5 because it's pretty expensive actually for the patients to come off of the pocket,
Yeah, no. Right there. I agree with you there.
There is always a possibility also to go to another kind of DOAC. For example, apixaban is currently also now generic available. You can apply a reduced dose of apixaban as well, even though there are no trials comparing this. So this might be an option for a highly thrombotic risk patient.
Right.
But I agree with you that the costs out of pocket for the patient are limiting step for this approach.
Okay. This is important. Okay, guys. So I think we what we've done is Vishal is doing a great job here ballooning both vessels. We're going to come down with the balloon and we're going to take a quick picture, and then like I said, if we might need to stent the TPT, we will. We went with a 4.0 balloon into the posterior tibial just to be able to get that posterior tibial open. He's just going to pull it back to the SFA in case we have to do other sort of stenting. And Flora, off.
Yes. Off, Flora. Good.
Okay, and we're just going to take one lag picture. Okay, Cindy?
No, hold on. Perivision.
Okay, let's hopefully this is all we need. Inject.
Beautiful.
Yeah, I think
we're beautiful. Done. There you go.
Much better.
Yeah, I think we're done. Yeah. So we're going to stop here, gang. Again, Ray came off the, not Ray, Vishal came off the pedal too early, or Haroon did. So I think it's important to always show the delayed cine, and I think it's very important. So, but anyway, I thank everyone. I thank our team, of course, Elizabeth, everyone here for doing such a great job. Elizabeth was very kind, and I think we're ready to go to our next case. The only thing I do want to say, the next case is not the last Wednesday of the month. It's the Wednesday before. Karthik, can you?
Well, it's 22nd. It's 22nd then. 22nd.
22nd of next month is the live case,
Yeah,
and
sorry, my fault.
and this way everybody will see you there. I hope you had a good learning experience, and we look forward to your comments. Thank you, guys.
Thank you.
Thank you.
You want to close?
Thank you.
Thank you.
Thank you, PK.
Excellent.
Great case.
We'll just close off with some comments.
Yep, you can close off some comments.
Good.
So this was actually a very nice demonstration of how to cross a challenging CTO in a popliteal, in a region where we primarily not anticipate implanting stents. So we demonstrated an antegrade approach and a retrograde approach in two CTO caps, proximal and distal, which were not actually very favorable. We escalated wire techniques. We came from above and below. We used different kind of support catheters. We used the Snare device and we flossed then the wire out. Then we applied our therapy with PTA and DCB, and we fulfilled the approach of not leaving nothing behind in this segment. So thank you everybody for watching us. And watching Dr. Krishnan doing this case, and we'll see you in the next live case at July 22nd. Thank you.
Thank you.